let's just start with our July questions. Yeah.
Okay, perfect. So let's get started.
Yes, doctors. Hello, doctor. This is me, Dr. Neelofar Abro, and here I'm going to discuss the questions with like July exam questions. So, and I will show you that how we prepared the files and with the explanation and everything. So, just 1 minute. Yeah. So this is our day one. These are the questions which came on the day one, like in the exam week on the day one, like on Monday, mostly like just in August. Our day one will be on 12th August, Monday. So every time the exam will start on Monday, and the last day of the exam is Saturday. So therefore, we have 5 days in a week, like from Monday to Friday, we have 5 sessions. And in like all in every day, like I try to explain all the questions which came in the exam. And yes, I'll try to repeating the questions again, if I discuss the questions on day first, I'll try to omit that questions on day two, and I will explain new questions on day two which come on the day two. So in this way we will cover all the exam questions of the July. So if you have exam on last day of August, then it is good that you will attend all the 5 day sessions. And if you have exam, definitely if you have exam on day three, like then you will attend day one and day two. So in this way, you will get all the questions with explanation. Otherwise, because I'm not repeating the questions all the days, if because I have only 2 or 3 hours for the session, so it is not possible that I repeat all the questions again and again. So this little bit about my exam week session. So this is like in here, because I will try to explain all the questions because I have like 5 days, so definitely they are the 5 files, so it's not possible for me to discuss, but I will try to discuss each and every question today. To in this way you will find this sessions helpful. Okay, so let's start our question number one. A child with
Excuse me,
microcephaly.
Dr. Abro, are you in Sydney here? Are you in Sydney in Australia?
No, doctor, I'm not in
Hello?
Sydney.
You're not in Australia?
No, I am in
Sorry.
Australia, but I'm not in Sydney, doctor.
Okay.
Yeah. Thank you.
Sorry about that.
Okay, so child with microcephaly, cleft palate with six fingers in right hand. So now here we have three getting point. In to solve every time to for solving the questions, I always tell my students that my dear doctors that please try to find the key points, because in the exam definitely our questions are like a long scenario, so it is difficult to solve the whole question within 1 minute or within 2 minutes. So it is good that if you know about the key points, then you will solve your question quickly. And second, always first read the options, like what are the options. In this way, you will quickly solve your question. First, I will read, if I read the options like this: Down syndrome, Edward syndrome, Petar syndrome. So it means this question is related to the trisomy, trisomy disorder. So in this way, now when I read the question, I will find that these three key points: microcephaly, cleft palate, and six fingers in right hand. These three things are most common in which trisomy disorder, like in Down syndrome, in Edward syndrome, and in Patau syndrome. Now let's read these all, because we don't know that what is the right answer. So it is good whenever doctors, this is my tip, that whenever you solve the recall, try to read all the options. It is not like, we know that mostly doctors know that the six fingers comes in the Patau syndrome, and then we mark the Patau syndrome and move forward. No, it is good to read Down syndrome, it is good to read Edward syndrome, and it is Patau syndrome. Like you, it is good to read all the syndromes. And because maybe on day first they give the question related to the Patau syndrome, maybe on day two they give the question related to the Down syndrome. So recall, solving of recall means solving of whole topic. It is not like just read the question and mark the answer. No, and just learn the answer. No, solving of recall means read the whole scenario, whole topic, all the topics which comes in the options, all the topics. So let's read our explanation. So in this way, we in exam week we solve our questions. Our sessions will be helpful for you because we give you the recalls, like we provide the recalls as well with the explanation. I'm not sure that I'm not saying you that I will give you the 100% right answer, because definitely the 100% right answer is from like the 100% right answer only knows the AMC knows the 100% right answer, not other doctors. But yes, I will give you the hint, I will give you the key points, and I will give you the explanation. And I am sure that with that explanation, you will be for sure you will mark the right answer in your exam question. Because with the recalls, we don't know what is the real exam question. But yes, with explanation, definitely you will be helpful to mark the right answer. So with my explanation, you just read each and everything in the explanation. Like if I in the exam week, I will provide you the day one file, day two file, and all the files, and just read each and everything in the file, all the explanation, and then I am sure that you will definitely pass your exam. Okay, doctor. So these are the trisomy disorders. Summary: humans have 23 pairs of chromosomes. A trisomy is a chromosomal condition characterized by an additional chromosome. So a person with a trisomy has 47 chromosomes instead of 46. So this is the thing. Doctors, definitely this session is only for doctors and for those who have exam in AMs, who have exam for this AMC, Australian Medical Council. Definitely this session is only for doctors. But if you are not doctor, if you are anything, if you are nurse or anything else, you can participate in the session, or you can for your knowledge. Yes, doctors. So a trisomy is a chromosomal condition characterized by an additional chromosome. A person with a trisomy has 47. This is the thing. Therefore, we can call them trisomy. Has 47 chromosome instead of 46. 46 is normal. Down syndrome, Edwards syndrome, and Patau syndrome are the most common forms of trisomy. Risk factors. What are the risk factors? The condition of an extra chromosome usually occurs spontaneously during conception. The cause of this is unknown and prevention is not possible. The most important risk factor for trisomy condition is maternal age. Women in their late 30s and 40s have a higher chance of trisomy condition occurring. I put this explanation here because in the exam question, in the real AMC exam question, they give you the scenario and definitely they will give you the maternal age in that question. From the maternal age, you will consider that maybe this is the trisomy. So because this is the most common risk factor. So definitely they will give you the maternal age into the exam question. Trisomy 21 Down syndrome. So now let's discuss what is this Down syndrome. In Victoria Down, we mostly, I always try to like give it the explanation from Australian guidelines. From RACGP, some guidelines like have not the like some topics have not any specific guideline, because here there are different states, and some for some topics that different states have the different explanation. So therefore, in some areas you will find the Victoria, in some areas you will find the South Australia, and some areas mostly with the gynae topics we go with the South Australia guidelines. So here in Victoria, Down syndrome affects about 1 in 300 pregnancies. Down syndrome is also known as trisomy 21 because the person has 3 copies of chromosome 21 instead of 2. Okay, so some of the physical characteristics of Down syndrome may include, what are the, so now from this physical characteristic, these are very important. Just read all these characteristics because with this explanation, you will mark your answer. Slight upward slant of the eyes. Nearly all people with Down syndrome have a slight upward slant of the eyes. There can also be a small fold of skin on the inside of the eye called an epiphanic fold, and small white patches on the edge of the iris of the eye. Characteristic facial shape. This is very like a characteristic shape, facial shape, and the face of a person with Down syndrome is often rounded and tend to have a flat profile. Smaller stature, babies with Down syndrome are usually smaller and weight less at birth than others. So these are the characteristics findings for the Down syndrome. So now let's move to the Edward syndrome. In Victoria, Edward syndrome affects about 1 in 100 pregnancies. As definitely we know that Down syndrome is more common as compared to Edward and Patau syndrome. Some of the characteristics of Edward syndrome may include physical irregularity of the kidneys, ureters, heart, lungs, and diaphragm. Cleft lip or cleft palate, small skull, microcephaly, and malformation of the hands and feet, including missing thumb, club feet, and webbing between the fingers and toes. So this is the catching point for our question. In our question, this is microcephaly. In our question, this is microcephaly. In our question, this says cleft palate, but this is 6 fingers in right hand, not the missing finger. If in the question this is missing finger, then we will consider that this is the Edwards syndrome. But here they are saying 6 fingers. It means it is not Edwards syndrome. It is something else. Now let's read the last topic, or we can say the last option, Patau syndrome. In Victoria, Patau syndrome affects around in 3,000 pregnancy, 1 in 3,000. Patau syndrome is also known as trisomy 13 because the person has 3 copies of chromosome 13 instead of 2. Some characteristic features are small skull, microcephaly, an abnormal opening in the skull, malformation of part of the brain, structural defects of the eyes, cleft lip or cleft palate, additional toes or fingers. So this is the point. Additional toes or fingers. So now it is clear. Maybe if on the day first they give you the question with the additional toes or fingers, they say that they are the 6 fingers, so we marked Patau syndrome. Maybe with the other candidate, this is the point. Some doctors told me that Dr. Neelofar, in my exam I had like 80 or 90 recalls, but still I am failed. Why? That's the reason that recalls don't come, like exactly same questions don't come for every candidate. Definitely this is the AMC and this is the very big exam, so definitely they will make some changes in the question. So it is good to read each and every option in the exam question. Like it is not like if my answer is Patau syndrome, definitely your answer will be same. No, if my answer is Patau syndrome, your answer may be the Edwards syndrome. So please try to read the question very carefully and then mark your answer. So if you know each and everything related to the question, then you will easily mark answer. Otherwise, if you mark the answer like my friend marked Patau syndrome, therefore I mark Patau syndrome, then you will fail. Sorry. So this is the thing. Now here, microcephaly, cleft palate, additional toes. Therefore, our answer is Patau syndrome. But for Edward, what was for the Edward? Microcephaly, cleft palate, and last point was missing thumb. So if it is, if in the question they said that the 4 thumbs or 3 thumbs, then oh sorry, 4 fingers or missing thumb, including missing thumb, club feet, and webbing between the fingers and toes, then we can say that maybe it is the Edward. So in the question, in the exam question, if they say that they are the only 4 fingers, missing thumb, then we can consider maybe it is the Edward syndrome. So this is the explanation of question number 1. So I will show you the question again. This is the child with microcephaly, cleft palate with 6 fingers in right hand. What is the trisomy? Maybe in the exam, they will not give you the like name of the syndrome. Maybe they will give you the number of the trisomy. So I show already, I show you here that Down syndrome is trisomy 21. If your answer is Down syndrome, mark trisomy 21. If your answer is Edwards syndrome, mark trisomy 18. And if your answer is Patau syndrome, then mark trisomy 13. So this is, I already show you the explanation as well, that Patau syndrome is also known as trisomy 20 because the person has 3 copies of chromosomes instead of 2. So if instead of Patau syndrome, if they give you the option trisomy 13, then mark trisomy 13. So let's move to the next question. Yes, doctor. So let's move to the next question. Eosinophilic esophagitis, first investigation. Very important question. In 2024, every month they give this question. Every month. Eosinophilic esophagitis, first investigation. So here, I'll put all the explanation from the RCGP guideline. Let's see what is the question. Eosinophilic esophagitis, first investigation. I give the complete like a scenario from the other month. Like this question comes in, I think in June or maybe in May. The 7-year-old girl noted a sense of food stuck on her throat while eating chicken nuggets. Patient drank some water and noted relief of symptoms. This has already happened a couple of times previously and has always been relieved by drinking water. Patient noted to have history of mild eczema as well. Examination normal. What is the next investigation? They are saying next investigation. Here we are confused that whether it is eosinophilic esophagitis or global sensation, because here they are asking investigation, but sometimes they ask the diagnosis as well. So doctors, this is eosinophilic esophagitis. Why I'm saying this? Number first point, mild eczema. As we know that with this eosinophilic esophagitis, we have these allergy symptoms, mild eczema, asthma, these things as well. So mostly the patient who have mild like eosinophilic esophagitis, sometimes they have this mild eczema as well. Second point is relieved by drinking water. This is the point that when eosinophilic esophagitis, in eosinophilic esophagitis, when the food is stuck in the throat, they drink water and they're relieved by drinking water. So these 2 points, I will, with these 2 points, I will go with eosinophilic esophagitis. Now they are saying, what is the next investigation? Doctors, in the AMC exam, this is also the point that why doctors fail their exam. Mostly doctors fail the exam with 249, 248. Mostly I received the messages that Dr. Neelofar, I had only 249 marks. I failed with only 1 mark. I failed with only 2 marks. Now, what is this? So actually the problem is that you don't read the last line. In this question, this is eosinophilic esophagitis. I'm agree with this. And endoscopy is the diagnostic test of eosinophilic esophagitis. I am also agree with this. But here they are asking next investigation. Here this question is not like this question. This patient comes with these symptoms, but here only that food is stuck in the throat and then with drinking water, we are considering that this is eosinophilic esophagitis. But as RACGP says, if one patient comes to you with these symptoms, your first step always will be trial of PPI. Now I will give you some explanation, like I will give the some points. Just 1 minute, doctors. Yeah. So here, this is eosinophilic esophagitis, and as we know that the most diagnostic test for eosinophilic esophagitis is endoscopy. But when we will do endoscopy, there are some red flag points. Maybe if you check the definitely if you are appearing in, if you will appear in AMC exam, definitely you have the JM John Motak, the most important book for AMC. In that course, in that book, in the dysphagia chapter, there is on the day, I think on page first or second page of the dysphagia chapter, there is one table, and that table is related to the red flag points. If you find any red flag point in your question, then your answer will be endoscopy. You will not go with the PPI then. Your answer will be endoscopy. Because RACGP also says this point that sometimes with dysphagia, we do the endoscopy first. But still PPI trial is important, but we do the endoscopy first. because of the dysphagia, and dysphagia is the red flag point. Now the question is only dysphagia. Like if the red flag, only dysphagia is there in the question, then it is red flag or not? No. Then we will not consider it is a red flag, but we will not consider endoscopy at that time. Then we will check the age of the patient. If age is more than 50, then we will say that two red flag. Now, two red flag points are in our question. Now we will do the endoscopy. But with only dysphagia, we will not do endoscopy first. So please remember these points, then try to solve these dysphagia question. In JM, in the dysphagia chapter, in the table of the red flag points, it is clearly mentioned that these are the red flag points. And if any red flag point, if you see any red flag point, then you will do endoscopy first. Otherwise, you will do the other test related to the problem. But for example, if this question, this is the dysphagia, like the patient has problem with the eating, this is the to some extent we can say that this is the dysphagia, but the age of the patient is only 7 years old. Definitely for this patient we will not consider the endoscopy first. What we will consider? We will consider trial of PPI, that maybe this patient has the GERD. So therefore I will go with the trial of PPI. But doctors, if the same question, same dysphagia question comes with the 50 years old or 55-year-old patient, then I will consider endoscopy first. Because weight, oh sorry, not weight, age. Because age and dysphagia, both are red flag point for endoscopy. And at that point, my answer will be endoscopy. So this is the explanation. If this question, this is the dysphagia question, if this question comes with 55-year-old patient, then I will do endoscopy first. Why? Because RSAGP says, if there is any red flag point, do endoscopy first. But for this patient, because the age of the patient is only 7 years old, here only one red flag, which is dysphagia. So definitely I will do PPI, trial of PPI first. Why I am doing trial of PPI? To confirm that whether it is eosinophilic esophagitis or maybe something else like GERD or anything else. So therefore, our next investigation will be trial of PPI. Now let's see the explanation. Clinical assessment and indication for specialist referral. Clinical assessment in the first step and diagnosis of eosinophilic esophagitis is suspected. The most common symptoms of eosinophilic esophagitis in adults are dysphagia and food bolus impaction. Other symptoms include chest pain and heartburn. Approximately 50. These are the clinical assessment. I will show these are the presence of other atopic condition such as asthma, allergic rhinitis, and atopic dermatitis, or a family history of these conditions. Sorry, increases the likelihood of the diagnosis of eosinophilic esophagitis. Not only the presence of this condition, but also the family history also make the likelihood of diagnosis of EOE. Now, differentiate between eosinophilic esophagitis and GORD. Therefore, we will go with the PPI trial first. I want to show you the diagnostic criteria. This is the diagnostic criteria. The diagnosis of eosinophilic esophagitis can be made in an individual with typical clinical symptoms and biopsies of the eosinophilic demonstrating at least 15 eosinophils, 60 eosinophils per m. Here, there's one question, and in that question, I will show you that question as well. Okay. Diagnostic criteria for eosinophilic esophagitis based on expert research at the 2007. These are the symptoms of the eosinophilic dysfunction, and these are the symptoms. Okay. This is the point. This is from RSCGP guideline, investigations and diagnosis. How we will diagnostic, what is the diagnostic criteria of eosinophilic esophagitis? Symptoms related to eosinophilic dysfunction more than or equal to 15 eosinophils. of eosinophil biopsy. Like when we do the endoscopic biopsy, then more than or 15 eosinophils must be there. Now, I want to explain this question as well, because mostly doctors, they confuse with this question, that in the exam question they say, in the exam question, the scenario is related to the eosinophilic esophagitis, and this is that endoscopic biopsy is already done, and eosinophilic esophagitis is confirmed. Endoscopic biopsy is already done, and there's the more than 15 eosinophils are there on biopsy. Now your diagnosis is confirm that it is eosinophilic esophagitis. Now this is what is your next step. Then doctors confuse. They says that mostly doctors says that they are asking next step, I will do the PPI trial first. Why you are doing the PPI trial? If the patient, why we do the PPI? We do the PPI to distinguish between GERD and eosinophilic esophagitis. But if patient is already diagnosed with eosinophilic esophagitis, then what is the role of PPI in that patient? There will be no any role. There is no any role of PPI in the treatment of EOE. No any role of PPI in the treatment of eosinophilic esophagitis. No. Why we do the trial of the PPI? To just distinguish between GERD or eosinophilic esophagitis. But if in the question they says that these are the symptoms and biopsy is already done, and in biopsy more than 15 eosinophils are there, it means that this is the diagnostic criteria, and this is from RCGP. This is the diagnostic criteria of eosinophilic esophagitis. That is the symptoms, and more than 15 eosinophils are there. Then it means that this is confirmed case of eosinophilic esophagitis. And then our next step will be treatment of this eosinophilic esophagitis. And the treatment is, according to the step, omit the thing which caused the food which caused the problem, and then if they're asking the medication, then we will go with the budesonide or the fluticasone. Don't mark PPI in that question. If the patient is already diagnosed, don't make yourself confused with this question. Mostly I saw with mostly doctors, they says that no, because RCGP says initial step is PPI trial, therefore I will go with PPI trial. No. Why you are going? If the patient is already diagnosed with eosinophilic esophagitis, then there will be no role of PPI. Why we do the PPI trial? To make the distinguish between the EOE and the other problems. But if the patient is already diagnosed with EOE, if biopsy is already done, and more than 15 eosinophils are there, if the patient has symptoms related to the eosinophilic function, then it means that the patient has the problem of eosinophilic esophagitis. So we will treat the patient. We will start the treatment of the patient. And if there is the option of budesonide, we will go with that option. We will not do the PPI trial for that patient. Yes, doctor. So let's move to the next question. So these are the, now here actually I will show you the point where mostly doctors confuse. The initial diagnostic test for patients as suspected with eosinophilic esophagitis should be an upper GI endoscopy with biopsies. Initial diagnostic test. They are not saying initial step or your next step. If they are asking your investigation, then doctors try to mark the endoscopy. Initial diagnostic, because only we do the endoscopy and there's no esophagitis. But if in the question they ask what is your next step or what is your, because PPI trial is important in the case of eosinophilic esophagitis. Why it is important? If in the question nothing mentioned related to the biopsy, like biopsy is not done and endoscopy is not done, just patient comes with this food infection and with the drinking water history and all these things, now patient comes to you, your first step will be PPI trial. But if you already done the endoscopy and biopsies comes, eosinophils more than 15, patient is diagnosed with EOE, then your treatment option will be budesonide. Diagnosis requires persistent eosinophilia following a course of. It means PPI trial is important, and this is the initial step. PPI trial of a period for a period of 8 weeks as per ACG guidelines. Proceeding the Diagnosis of EO is important to distinguish between true EOE and GERD. Many patients undergo immediate upper GI endoscopy prior to commencement of PPI trial because dysphagia is an alarm symptom for cancer. That is the point which I already explained you. That dysphagia is the red flag point. Alarm symptom for cancer, dysphagia is the red flag point. Therefore, sometimes if the patient ages more than 50 and the patient has dysphagia, mostly doctors do the endoscopy first before the trial of the PPI. Repeat endoscopy following completion of PPI treatment could determine the persistence of eosinophilia. But if the patient is diagnosed with eosinophilia, again I am saying the same thing. If the patient is diagnosed with eosinophilia and they're asking what is your treatment, then please mark budesonide, don't mark PPI because they are asking treatment. Okay, so I'll show the treatment as well. This is the management. Treatment of EOE consists of eosinophilic esophagitis treatment. Management of eosinophilic esophagitis consists of dietary, pharmacological, and endoscopic interventions. So our first step is always our first step will be dietary. But in the exam, mostly they give the question related to the medical treatment. Mostly they give the question related to the pharmacological. So in the option, they give the PPI, budesonide, and the what we can say fluticasone. So I will give you the answer that when we will mark budesonide and when we will mark fluticasone because both are initial treatment and both are same. Okay, so one doctor asked when to consider C. So see this barium solo, doctor, for every this is true that for any eosinophilic can say the and this one esophagus, sorry, not eosinophilic, esophagus, for every like any esophagus condition, any condition, our first step, our first investigation, initial investigation always will be barium solo except eosinophilic esophagitis because there is no role of barium solo in eosinophilic esophagitis. So if the patient comes with the history of this food infection and drinking water and also the history of mild eczema, and you are considering that maybe this patient has eosinophilic esophagitis, then your first step will be trial of PPI and your next step will be endoscopy. But if the patient comes with the other symptoms of eosinophilic esophagitis like heartburn, regurgitation, and dysphagia with the solid or sometimes dysphagia with the liquid, if these types of the symptoms present in your question and you are considering that maybe the patient has GERD or maybe the patient has achalasia, maybe the patient has cancer or maybe the patient has any other problem related to esophagus, then your initial investigation will be barium solo and your next, or we can say the most diagnostic investigation will be related to the problem. Like if it is GERD, then your answer will be 24-hour pH monitoring. If your diagnosis is achalasia, then your answer will be monometry. So these are the different investigation, but your initial investigation always will be barium solo for any this esophagus condition except eosinophilic esophagitis. Okay, sorry. Here's our question. Yeah. So in the exam, mostly they give the question related to the medical treatment. But yes, our treatment always start with the dietary modification. We just eliminate the food which create the problem. You always omit that food. Mostly the patient has the allergy with 6 foods. Mostly milk, wheat, and these eggs, soya nuts, and seafood. Mostly the patients have with this allergy with these 6. They said that whenever I drink whenever I eat milk, mostly I saw the patient, they said that whenever I eat egg, I start the symptoms related to the asthma, like breathing problem and heartburn and all these things. So it is not the asthma, it is the problem, it is the eosinophilic esophagitis. It means that the patient has the problem with the egg. So we just eliminate the egg from her diet, of his or her diet. Same thing if the patient, sometimes we saw that the patient said that whenever we drink milk, whenever I drink milk, I start heartburn. So this is the thing that patient has the eosinophilic esophagitis. That it means that we just omit that food from his or her diet. So this is the first step. This is the first step, and if you confirm, if you diagnose that this patient has the eosinophilic esophagitis, definitely first you will do the PPI trial, and then you will do the endoscopy. If in the endoscopy you see that the patient has more than 15, the symptoms confirm and PPI trial fail, and endoscopy you see the more than 15 eosinophils on biopsy, then you diagnose that this patient has eosinophilic esophagitis. And then your next step will be targeted elimination diet. You will ask from the patient in the history that which food make you this problem. Like in our question, the patient has the problem with the chicken nuggets. So maybe the patient has the problem with the chicken. So what we will do, we just omit that, eliminate that food from her diet. So we will ask these questions. After this, if the patient said that is still the patient has the same problem, and with the elimination of the food from the diet, still the patient has the same problem, then your next step will be pharmacological treatment. Topical glucocorticoids, namely fluticasone and budesonide, are currently regarded as the initial therapy of the choice. Both are initial therapy. I'm not just saying that only fluticasone or only budesonide. No, both are currently regarded as the initial therapy of choice. And now problem is that in the exam they give the fluticasone and also the budesonide. And again we confuse that what is the right answer. Definitely in the exam question they will give you the hint, and the hint is budesonide is we will give the patient budesonide in the oral route, liquid suspension. But for the fluticasone we give in the inhaler dose. So I am sure that definitely they will give you some hint in the question. Maybe in the question, maybe they will ask the route, or maybe in the like options they give you the route, like oral budesonide. Sorry, or maybe they said that oral fluticasone. So if they said oral fluticasone, definitely our answer will be wrong, because we take the fluticasone in a inhaler. And if they said that inhaled budesonide, then definitely again our answer is wrong. Why? Because we take the budesonide and is available as the liquid suspension. So this is in this way we will distinguish that what is the right answer, fluticasone or budesonide. But still in the last, like still in the question, if the route is not mentioned, if in the option route is not mentioned, now what we will do, then your answer will be budesonide, because liquid suspension. So budesonide is available as a liquid suspension. So yes, then mark budesonide. If route is not mentioned into the question, and if route is not mentioned into the answers as well, then what will you choose from between budesonide and fluticasone? Then you will choose budesonide. Then your answer will be budesonide. But I am sure that they will give you some hint into the question. So this is all about our eosinophilic esophagitis topic. Okay, and this is all about all the explanation that and this all explanation is from the RHCGP guidelines. So let's read the next question. Young lady with epigastric
Excuse,
fullness,
excuse me,
alcoholic.
excuse me, excuse me,
Yes,
excuse
doctor.
me, excuse me, doctor. Are we going to receive PDF of this guideline and the explanation?
I think no, because this is like I think no, doctor. I'm not sure. You can ask from the Asma, the coordinator. But I think no, because these are our files, and so I think no. This is only like this webinar is
Because
only.
we can, the problem, yeah, yeah, the problem we can't write everything, but if we have it in PDF, it will be easy for us to read.
Yeah, then you can join the course, maybe then it will be helpful, because if you join the course, definitely you will we will provide you each and every explanation or of all the questions. Then no need of writing and anything. But yes, this is the only the free webinar. So In this webinar, I only explain the questions, but I think we will not provide you the PDF file. But still, I'm not sure, but I think we will not. Okay, doctor. So let's see.
Thank you.
Young lady with epigastric fullness, alcoholic history, and history of pancreatic weeks before probably pseudocyst management. So ERCP, MRCP, ultrasound, and CT. Yes, doctor, recorded will be provided. Yeah, you can, if you want to write everything, then you can see the recording of this video. Recording is
Okay.
provided. Yeah, so you can check from the Facebook page of the Medics Expert. So you will see the recording of this video. Yeah.
Thank you.
Okay. So next question is young lady with epigastric fullness, alcoholic history and history of pancreatitis weeks before probably cirrhosis management. This probably cirrhosis is according to on Facebook. Yes, doctor, on Facebook. Uh, if you are in the like if you already joined the Telegram group of the Med Exam Expert or if you join the WhatsApp group, then Asma will share. I think the coordinator they will share this recording into the groups as well. So
Oh,
yeah, or
I'm
maybe
on Telegram. Yes, I'm on Telegram.
yeah. So definitely they will share this video on their website, on their what we can say WhatsApp group, or maybe on the Telegram group, and also maybe they will share on the Facebook or maybe on the YouTube. So they will share.
Thank you.
What's the link of the Telegram? I think you can ask this from Asma, or in the last we will tell I will tell her that you can she will share the Telegram link with you all, because in that yeah
Or
in the
WhatsApp. I'm on WhatsApp with them on WhatsApp.
yeah, because in WhatsApp, yeah, they have the group in WhatsApp as well, and in the Telegram, and also on YouTube and Facebook. So everywhere, I think they will share this file. Oh, not the file, this recorded video. Yes, doctors.
Oh, thank you.
So young lady
Thank you,
with
Dr.
epic.
Dr. Abro. Do they have mock exams as well? Uh,
Yeah, they have. I think if you check their they have. I think I'm not sure, but you can ask from the coordinators. But they have the mock test as well, and also the and since February 2024, I am doing these sessions. So they have the all solved files as well. Like since February, they have all solved files, like just like this file, which I'm showing you.
no, I'm
So
just want a mock test. I think their mock test should be exam oriented, right? It's more suitable. I just
yeah,
suppose.
it is maybe definitely for the mock test, definitely they have the 150 questions and it is same as the real exam, definitely.
Okay, so
Yeah.
I will ask them.
Yeah, you can
Okay,
ask for that one. Yeah.
okay, thank you.
Maybe from in the chat box, the coordinator, they are sending the messages, so you can ask from them. Yeah. Yes, doctor. So let's. Yes, doctor. Let's move to the next question. Young lady with epigastric fullness, alcoholic history, and history of pancreatitis weeks before probably cirrhosis management. So here, this probably cirrhosis is according to the recaller. This word, probably cirrhosis, this is according to the recaller. So we just say that epigastric fullness, alcoholic history, and history of pancreatitis. They are asking management. And in the question, the options are ERCP, MRCP, ultrasound, and CT. So now let's read. Cirrhosis form when the cells of the pancreas become inflamed or are injured and pancreatic enzymes start to leak. Leaking of the enzymes harm the tissue of the pancreas. Pancreatic cirrhosis may start after an episode of sudden acute pancreatitis. Pancreatic cirrhosis may start after. So this is the catching point in our question, that there is the episode of pancreatitis in the patient. Patient with chronic pancreatitis can also get cirrhosis. They may also form in condition that cause long-term pancreas inflammation. Having gallstone and drinking a lot of alcohol. I am not sure with this question that this question is related with the, but I know the questions related to the cirrhosis, and in that question, always they give the history of drinking alcohol, a lot of alcohol. In the history, in the exam question, in the history, they give this catching point, drinking a lot of alcohol. Drinking alcohol. And second, yes, acute pancreatitis. So from these catching points, we will say that maybe this is the cirrhosis. Maybe this question is related to the cirrhosis and they are asking the management. But in the option, they are asking the investigations. Now let's see some other causes of the some other causes as well. Now, who is risk for pancreatic cirrhosis? You may have a high risk for if you have a health issue. This is the and drinking less alcohol may also lower your risk. So alcohol is very important point for this cirrhosis. Symptoms of the pancreatitis and cirrhosis may include these are the symptoms. Maybe in the exam they give you the symptoms as well. I put all each and everything here because in the exam, definitely the exam question, doctors, it will be like more clear question. The exam question will be more clear. Uh, 4 to 5 lines question. Sometimes they give the question of whole page as well. So in the exam question, they will give you the symptoms as well. In the history, maybe they said that the patient has the acute pancreatitis, and maybe they said that they give you the question just like they said the 30 years old patient who is alcoholic who take more alcohol and recently he has the problem of the pancreatitis and now patient comes to you with these symptoms. So they will give you the symptoms as well. Stomach pain, this may go around to your back, fever, swollen belly, nausea, vomiting, and abdominal mass detected on physical examination if this is the cirrhosis. So they will give you these symptoms as well for your diagnosis. Now, the severe pancreatitis may also cause dehydration and low blood pressure. Complications from cirrhosis may cause other symptoms as well. So, how are pancreatic cirrhosis diagnosed? So, now let's see what are the diagnoses. To diagnose pancreatitis, your healthcare provider can often confirm a cirrhosis with CT. To confirm pancreatitis, your healthcare provider may do tests. These may include, these are for pancreatitis. Yeah, here it is written, your healthcare provider can often confirm a cyst with CT or with another imaging test such as MRI. Confirm. They are not asking what is your initial investigation. They are saying confirm. Your provider may use a special internal ultrasound such as endoscopic ultrasound as well. So here in the question, the question is, let's see that what in the question they ask. Investigation. They are asking, we don't know, they are asking here, they are asking management. And the options are ERCPMR. So this is the like confusion for the like recaller that maybe they ask the management or maybe they ask these investigation. So if they're asking investigation, according to the this explanation, it is clearly mentioned that we confirm the pseudocysts with CT if the patient has the complication of pancreatitis. Doctor, please mute yourself. Just 1 minute. Yeah. If the patient has, yes, doctor, just for 2 hour session, 2 to 3 hour session. Yeah, mostly for the exam because sessions, I took the session for 2 to 3 hours. So yes, it is mostly 2 to 3 hours. So here it is confirmed that the last point is that here it is confirmed that for this, your healthcare provider can confirm a cyst. This is the cyst, or in simple words, I will say that your healthcare provider will confirm the complication of pancreatitis with CT or another imaging test with CT. And cirrhosis is one of the complication of pancreatitis. That is the point, therefore, I mark CT. Now let's read the topic acute pancreatitis, and this is from, as I already told you, that we sometimes if we don't find the topic from the RSCGP guidelines, then we will search that topics from the statewide guidelines. So this is from the NSW. This is one of the state of the Australia from NSW Health. Now let's read the acute pancreatitis that and what are the investigations, because we must know that what are the investigation for the acute pancreatitis and what are the investigation related to the complication of the pancreatitis. Step number 1, pathway the symptoms to consider: abdominal pain, upper. These are the steps. So I will, because I have only 1 hour left, so I will show you the important points only. Risk factors to consider, as I already told you, that alcohol is a very important risk factor, and second, gallstone. Here it is a 50% of the cases gallstone, and ethanol 20 to 25%. These are the other risk factors as well. Now, this is the patient stable or not? Detailed initial assessment. Diagnosis: serum lipase 3 times the upper limit of the normal is suggestive of the pancreatitis. Lipase remains elevated. This is very important point, doctors, because on this day second, the question was related to the pancreatitis, and they are asking what is your diagnostic test for this problem. At that time, we confuse that whether it is lipase or whether it is ultrasound or maybe CT. So in this question, it is clearly mentioned in this diagnosis point. Serum lipase 3 times the upper limit of normal is suggestive of pancreatitis. But lipase remains elevated for a longer period of time as a higher specificity as compared with the malase. However, a normal serum lipase level does not exclude the diagnosis of pancreatitis. It means that serum lipase is not the specific test. It is not the diagnostic test, because diagnostic tests mean that it is must be true positive. But here it says that if the serum lipase comes normal, it doesn't mean that this patient has no pancreatitis. If the patient comes with the symptoms of the pancreatitis, your initial investigation will be serum lipase. Initial investigation is serum lipase, not the diagnostic or confirmatory. Because if the serum lipase comes negative, or we can say normal, it doesn't mean that the patient has not pancreatitis. Then what we will do? We will do the other investigation, just like CT scan. So on the day 2, maybe I will show you that question as well. On day 2, the question comes related to the pancreatitis, and they ask what is your diagnostic test or what is your investigation for this problem. At that time, most doctors say that this is the serum lipase. No, doctors, because if they're asking diagnostic test, then your answer will be CT, not the serum lipase. We will do serum lipase initially, but here it is confirmed, like mentioned, it is 100% mentioned in this NSW guideline that normal serum lipase level does not exclude the diagnosis of pancreatitis. It means that if serum lipase comes normal, still the patient has the problem of the pancreatitis. So it means that it is not a confirmatory or 100% diagnostic test. It comes wrong as well. Now let's see the risk 5. Step 5 is the risk strategies. What are the risks? And now I will show you the last step, which is the imaging. To exclude, this is actually to exclude differential, for example, free subdiaphragmatic air and perforated viscous consolidation, or to look for complications of the RD and pleural effusion. So just X-ray. Abdominal X-ray not routinely done to exclude obstruction. If a differential if done, may show localized loss of a segment of a small intestine. Ultrasound. Early ultrasound recommended. May diagnose pancreatitis, gallstone, pancreatic cytosis in approximately 25 to 35 patients of percent of the patients with acute pancreatitis, bowel gas due to any less precludes evolution of the pancreas or bile duct. Contrast enhanced CT may be used for diagnosis if clinical and biochemical findings unclear, especially if alternative surgical emergencies considered. Not routine to perform early CT for assessing severity of the. We will not do early like CT, but we will do the CT. Contrast enhanced CT may be used for diagnosis if clinical and biochemical findings unclear. If the clinical and biochemical findings unclear, it means that the CT is the most diagnostic test. Like the CT is the last test to confirm if your other test, like we can say that the serum lipase, it comes normal, but still you're saying that the patient has the problems of the pancreatitis. Now what I can do? You will do the CT scan. It is clearly mentioned here that if clinical and biochemical findings unclear, then your next step will be CT. We do ultrasound Early ultrasound recommended may diagnose pancreatitis and these things in approximately 25 to 35% of the patient with acute pancreatitis bowel gas due to an illness precludes evolution of the pancreas or bile duct. So it is ultrasound comes in the early ultrasound recommended. But CT, if the clinical diagnosis is not made, it means that the CT is the diagnostic test. We always do the diagnosis and test in the last to confirm your diagnosis. If you are suspecting with the clinical, but you are not confirmed with the clinical findings, if you are suspecting, but you are not confirmed with the initial findings, if you are not confirmed with the initial investigation, just like serum lipase, just like they are saying biochemical findings are unclear, then you will do the diagnostic test, and your diagnostic test is CT. And this CT will give you the correct diagnosis. And also, ultrasound early recommended, but yes, we will do the CT as in the this explanation, it is clearly mentioned. Just 1 minute. Yeah. It is clearly mentioned that for the pseudocyst, pseudocyst is the complication of the pancreatitis, or we can say, yeah, pseudocyst is the complications. To confirm a pseudocyst, what we will do, we do the CT or any other imaging test, for, such as MRI. So what we will do, CT. So in our question, they give the history of alcohol and they give the history of pancreatitis. So we can say that maybe, probably cirrhosis. This is according to the recaller. And I'm also saying that maybe this is the alcoholic history and history of pancreatitis. So maybe this is the cirrhosis, and for cirrhosis we will do the CT. Not the ultrasound, then we will do the CT. It is confirmed from our explanation. And yes, if this question is related to the pancreatitis and they ask what is your next investigation will be serum lipase. But if they ask what is your diagnostic, or we can say confirmatory investigation, then your answer will be CT scan. And this is confirmed from NSW guideline. Okay, doctor. So let's move to the next question. Oh, sorry. That's the question. Okay. Yeah. So these are, and also I put the management as well. So these all steps. I have no time, but you can read. You will find this explanation if you search in the Google, just write it. This acute pancreatitis NSW guidelines. You will find all these explanation, and these are the 7 steps. So just read all these steps, and then you will be clear. And this in the step number 8, so you can create complications as well. So pancreatic cirrhosis is the complication of the pancreatitis. Now, next question is diabetic man travel to Vietnam, comes with fever, cough, skin lesion. What is the diagnosis? So it is more towards myeloidosis, because these type of the question, because we know that these are the findings, and because I will try, because I have only 1 hour left, so I will try to explain each and every question. So for this question, this is very straightforward question, so therefore I mark this myeloidosis and I put this one. So here in the question, they are saying the travel to Vietnam comes with fever, cough, skin lesion. What is the diagnosis? Skin lesion. So I'll mark the myeloidosis. Okay, doctors, let's move to the next question. And I put all the explanations as well related to the myeloidosis. And also the malaria and all these things. An elderly female 30-year urine examination shows 20 WBC and culture E. coli, but no symptoms. No symptoms. What to do? So yes, again, what RACGP says, this is the point. RACGP says that asymptomatic bacteriuria, if there's no symptoms, but in the culture E. coli is present, because we know that E. coli is the most important, or we can say the most common this bacteria for this UTI. So E. coli, if in the culture E. coli is present, but patient has no symptoms, what we will do? We will not treat the patient. We will not treat the patient, even for the elderly as well. Do nothing. This is the explanation from RSCGP. Asymptomatic bacteriuria is common in the elderly. Asymptomatic, especially among institutionalized or hospitalized patient. The risk factors include cognitive impairment, diabetes mellitus, cultural urinary tract abnormalities, and indwelling catheters. Antimicrobial therapy does not result in improved survival or genitourinary morbidity and may potentially cause available side effects and the emerge of the resident organism. So, from this explanation, it is clearly 100% like just confirm that we will not treat the elderly patient as well. If the patient has no symptoms, then we will not treat the patient. Even the culture comes positive for the E. coli. So don't confuse that because I saw the doctors, they said that the doctor here the patient is elderly. Even you will not treat. I said no because RSCGP says for the elderly as well, we will not treat the patient. We only treat the pregnant patient, and this is written into the JM. In the UTI chapter in the JM, it is clearly mentioned that we will treat the patient if the patient is pregnant. Otherwise, we will not treat the patient, even for the elderly patient as well. And yes, for the pyelonephritis as well. For the pyelonephritis and for the pregnancy, we will treat the patient. Otherwise, we will not treat the patient. If the patient has no any symptoms. But yes, if the patient has symptoms, then we will treat the patient. Along the scenario about patient on warfarin previously for upper respiratory tract infection receiving multiple AB treatment, non-city, abdominal large mass like appeared in anterior abdominal, no fever, just abdominal pain. Very important question since 2000, I think October 2023, this question comes every month. This question is repeating every month. This is the other three different, we can say that the CT scan. Just read all the CT scans. For this question, doctors try to read all the CT scans related to the source abscess, related to the rectal sheath hematoma and ureteral stone as well. Now, and second point for this question, here, as I remember, I think in the Amidex, QBank, in any on QBank, there's the question related to the warfarin, and the answer was rectal sheath hematoma. Now, every doctor says that, mostly doctor says that if the history of warfarin is there, then our answer will be rectal sheath hematoma. No, doctors, it is not compulsory that with always with warfarin history, your answer will be rectal sheath hematoma. No. Your answer will be hematoma, but not always rectal sheath hematoma. This is the confusing here. The recaller wrote over there that a large mass-like appeared in the anterior abdominal wall. No fever, just abdominal pain. It is large mass-like appeared. This is according to the recaller, mass-like appeared on the anterior abdominal. So now it is according to the recaller, it is confirmed from the recaller that that mass was on the anterior abdominal wall. Therefore, I marked rectal sheath hematoma. But if it is not on the anterior abdominal wall, if it is somewhere else, then consider any other hematoma because in this question they give you only these options, but in the other question, maybe on the day 2 or day 3 file, you will see you will check that question. That in that question, the options were there's the other hematomas as well. And in the question, the recaller said that this mass, or we can say the hematoma, was not on the anterior abdominal wall. If it is not on the anterior abdominal wall, then your answer will not be rectal sheath hematoma. No. If it is on the anterior abdominal wall, then your answer will be rectal sheath hematoma. So please, doctors, clearly read your CT scan. It is not like that if it is warfarin history is there, then I mark rectal sheath hematoma. Why you mark rectal sheath hematoma? Because there's the warfarin history. No. It is not compulsory that with every warfarin history, the hematoma comes on the anterior abdominal wall. No. Maybe this bleeding, because hematoma is bleeding, maybe this bleeding can happen somewhere else. So just read all the CT scan related to these topics and mark the answer according to the CT scan. For the source sepsis, yes, there's no fever, so therefore this is not source sepsis. And ureteral stone, definitely this is not there are no any signs symptoms related to the ureteral stone, and the ureteral stone CT will be more different. So here, according to the recaller, the mass is on the anterior abdominal wall, therefore I marked rectal sheath hematoma. Okay, doctor. So this is the same question. 10 years old girl complains of dysphagia and feeling of food getting stuck in the throat every time she eats. Have this complaint for the past 7 months. No abnormal findings, mild eczema diagnosis. Again, one important point for you doctors that if the dysphagia, as I already told you this thing, that if there is only dysphagia, when the question only dysphagia is mentioned, then it is not the red flag point. But if the dysphagia more than 5 years, it is the then it is the red flag point. Then we will not check the age of the patient. This is according to the RCGP guidelines that if this dysphagia, if dysphagia is the patient has only the symptoms of dysphagia and age of the patient is less than 50, then it is not the red flag point for the cancer and we will not do the endoscopy. But if the patient has dysphagia more than 5 years, if the patient has the dysphagia means GERD gut problem more than 5 years, age of the patient is less than 50, but the problem of the dysphagia is more than 5 years, then we will do endoscopy. Why? Because dysphagia more than 5 years is the very big red flag point for cancer. So please try to find all of these points in your question. I wrote these points in these bullet points for you. Age, if age is less than 50, age is less than 50, maybe 40, 30, 20, anything, plus dysphagia for 7 months. Less than 50 age and dysphagia for 7 months. Your next step will be PPI trial for 8 weeks. We will not do endoscopy in this patient. Even there is the history of dysphagia, but dysphagia is less than 5 years. And second, only dysphagia is not the red flag point. Please, doctor, this is 100% right thing. Only dysphagia is not the red flag point. So, therefore, I will mark PPI. I will not do endoscopy for this patient. I will try to go first. I will try give the trial of the PPI. Maybe the patient will relieve with the PPI. Next, if the age of the patient is 50 plus, more than 50, dysphagia for 7 months. Next step, endoscopy to rule out cancer first. Why I am doing endoscopy for this patient? Because this patient has dysphagia plus age of the patient is more than 50. JM says if two red flag points are there, endoscopy will be the answer. This is the point. This is the difference between these 2 points. Dysphagia for 7 months, dysphagia for 7 months. Age is less than 50. Only dysphagia is not the red flag point. Therefore, I mark PPI. Maybe the patient will relieve with PPI trial and no need of endoscopy. But if age is less than 50 and the dysphagia is for 7 months, it means that dysphagia and also the age both are red flag points. So now 2 red flag points are there. Definitely, I will go with endoscopy first to rule out the cancer. Age is less than 50, plus dysphagia more than 5 years. Age is less than 50. The age of the patient is 20, but the patient has dysphagia more than 5 years. Next step, endoscopy to rule out cancer. Why I am doing endoscopy? I'm doing endoscopy here. Age of the patient is 50, less than 50. Why? Because dysphagia more than 5 years is the very big red flag point for cancer. Therefore, I marked endoscopy. Please, doctors, remember these points. If you want to take a screenshot, you can take the screenshot and just remember these points are very important. Written by me. but definitely these points are from RACGP and confirmed points. Patient already diagnosed with EOE. Patient is already diagnosed, doctors. More than 15 eosinophils are there and they're asking appropriate treatment. Definitely you will go with the steroids, budesonide or fluticasone. Don't mark PPI. Please don't mark PPI. This patient don't need PPI because PPI has no any role in this patient. Because this patient is already diagnosed. This patient has the symptoms of EOE, history of asthma, and also endoscopy is already done and eosinophilic is more than 50. If this patient is already diagnosed and everything is done, if you give the 8-week trial to this patient, then there's no role of PPI. Like if this patient is like for 8 weeks, still she's like the patient is waiting for the treatment. You are just giving the trial of the PPI to distinguish between the GERD and EOE. If the patient is already diagnosed, then no need of trial. Na? So don't give PPI trial for this patient. Just start the treatment of with the steroid, because the steroids are the most appropriate treatment for this patient. So these are the important points. And these are confirmed from the JM and also from RSCGP. I just make these in the bullet points. So you just remember these points and mark the answer according to these points. Yes, doctors. And because in November 2024, there was one question related to the GERD. In that question, they says that the patient has like heartburn. The patient has heartburn, regurgitation, since and the patient took the NSAIDs, and now the patient has the and no, the patient take the NSAIDs since 5 years. Yes, that question was like this, that the symptoms are related to the GERD, and they said that this patient has these symptoms since 5 years. Now, what is your next step? At that question, your answer will be endoscopy. Still, there was option of PPI was there, but we will not do PPI. Oh, sorry, PPI 24 hours pH monitoring. The question was, I'm again repeating, sorry. The question was the patient with the symptoms of the GERD, like heartburn, regurgitation, all the symptoms of the GERD was there in the question. And they asked, what is your most, and the patient had these symptoms like since 5 years. And the patient took the NSAIDs as well for the relieving of the problems. Antacids. And now they says, what is your most appropriate investigation for this patient? We know that the patient has GERD, but the problem is that the patient has these problems more than 5 years. Therefore, we will not mark 24 hours pH monitoring for that patient. We will mark endoscopy for that patient. Why? Because that patient has history of GERD more than 5 years. So this is the very red flag point for the Barrett esophagitis, or we can say for the cancer. Therefore, we do the endoscopy for that patient. During November 2023, mostly doctors, they confused. They said that this is the question of the GERD, and they are asking diagnostic test for the GERD, and the diagnostic test for the GERD is 24 hours pH monitoring. I am agree with this point, that the diagnostic test for the GERD is 24 hours pH monitoring, but the problem is that the patient has that symptoms more than 5 years. And dysphagia or the symptoms of the GERD more than 5 years is a very big red flag point for cancer. So therefore, we do endoscopy in that patient. We will not do 24 hours pH monitoring. That's the question. Maybe you will find that question in the November 2023 files. Okay, doctor. So let's move to the next question. Okay, doctor. So let's move to next question. This is the CT scan imaging. Okay, so this is that question. Rectus hematoma, hepatoperitoneal hematoma, source abscess. This is the rectus sheet hematoma on the anterior. So if the hematoma, this is the hematoma, this is the white, you can say that the mass that's in the previous question, the recaller said that the white mass on the anterior abdominal wall. So this is the white mass or white patch, anything. This is actually this is the hematoma. This is the bleeding. So if this hematoma happens into the anterior abdomen, this is the anterior abdominal wall. If the hematoma comes under the anterior abdominal wall, then this is rectus sheath hematoma. But if this is not on this is somewhere here, then maybe it is because if maybe it is in the retroperitoneal area, then we can say that this is the, so please try to read all the hematoma. Maybe it is the retroperitoneal hematoma, maybe it is rectus sheath hematoma. Don't say that it is the if there is the warfarin history, the answer will be rectus sheath hematoma. No, this is not compulsory that with every warfarin history, the answer will be rectus sheath hematoma. No, maybe this is somewhere else. This hematoma, or we can say that this bleeding occurred in other part of the, or we can area of the body, or we can say the area of the abdomen. So try to read or try to learn all these CT scans and mark your answer according to the CT scan. Don't mark your answer according to the scenario. Mark your answer according to the CT scan. And I'm sure that the CT scan quality of the AMC is good, not the X-ray. X-ray qualities are not as such good, but the CT scan quality is good. Okay, doctor. So let's move to the next question. Kidney stone 7 mm ultrasound mild hydronephrosis. Management ASWL PCNL instant. So 7 mm, 0.7 centimeter. Mild hydronephrosis. Now I have one. This is very like definite. Maybe you will, you doctors also saw this picture in the other. This is very good, like we can say that very good reference for this thing. And if the stone is in the, sorry, just I show you the, yeah, anywhere other than lower pole of the kidney. If it is anywhere other than lower pole, it means if it maybe it is in the middle pole or middle portion of the kidney, or maybe it is near to the ureter, or maybe on the upper pole. If it is anywhere in the kidney except lower pole, then you will check the size. Up to 0.5 centimeter, it passed spontaneously, no intervention. 0.5 to 2 centimeter, ESWL, more than 2 centimeter, PSCN. If renal stone is comes to the lower pole, not in the middle, not in the upper, in the lower pole, now your size is little different. Up to 1 centimeter ESWL, between 1 centimeter to 2 centimeter nasal lithotripsy, and more than 2 centimeter PCNL. If now we come towards the ureter, if the stone comes in the ureter, if the stone is in the ureter, proximal is ureter. Proximal means the area which is near to the kidney. This is the ureter. We know that the ureter, it starts from the ureter, goes down. If the portion of the ureter near to the kidney is called proximal, and the other portion of the ureter is called distal. So in the proximal ureter, up to 1 centimeter ESWL, more than 1 centimeter PCNL. Distal ureter, the other portion of the ureter, distal ureter, between 0.5 to 0.7 centimeter, observe with TEM solution. If there is hydronephrosis, then we will do the stent first. If more than 0.5 centimeter, we will do the ESW1. So hydronephrosis, if in the question, in our question it says mild it mild, we don't know that maybe in the question they use this mild hydronephrosis, or maybe they give the symptoms of the mild hydronephrosis. So if in the question hydronephrosis is there, if in the question they said not mild, hydronephrosis, if there's the hydronephrosis is there, please doctors marked stent. Don't make yourself confused, please. For my students, I always tell my students that please don't make yourself confused. In the AMC exam, the question is like very lengthy, and we have only few minutes. We have not like 5 minutes to solve one question. We have only few minutes, like only 1 minute, or more than, like maximum we have 1.5 or 2 minutes. So please don't make yourself confused that, and don't waste more time on one question, that whether it is ESWL or whether it is a stent, because some doctor says that with hydronephrosis still we don't do the stent. No, for hydronephrosis, if in the question they use hydronephrosis, or they give the symptoms or the signs related to the hydronephrosis, please mark stent first. But if there is no hydronephrosis, then yes, then mark the answer according to the size. Mild in our question there is mild. Mild is nothing. Hydronephrosis means hydronephrosis. What is mild? Mild is nothing. So if there is only hydronephrosis, what is there? Then then our answer will be stent. If there is no hydronephrosis, then our answer will be according to the size of the stone. In our question, it is more than 0.7 centimeter. Therefore, I marked ESW1. ESW1. Okay, doctor. So now let's move to the next question. Intern saw a medical student go on his relatives records what to do. Very important question, and every time this questions repeat as well. So warn him in this type of the question. If you see the medical student or any of your, or maybe your colleague or any doctor, sometimes the question comes with the junior doctor, sometimes the question comes with the colleague, your colleague, sometimes the question comes with the medical student. If they are saying the relatives record, just tell them. Then just your first step will be just tell them, or that warn them that please don't do this thing. This is not good, and don't check this file of the patient. So we just warn the doctor or colleague or junior doctor or medical officer, anyone. We just warn them that don't do this again. Yes, but if the doctor do the same thing again, second time, third time, and you are saying that this doctor is not like he's doing same thing again and again, then you will inform the coordinator, like the coordinator of that patient, oh, that doctor. If he's the medical student, definitely there's someone supervising him. So if this first you will talk with that medical student. If he's doing the same thing again and again, then you will tell the same thing, then you will inform the supervisor of that medical student. Because in hospitals, for these medical students, there are some supervisors who supervise that medical students. So your first step will be just talk with the medical student and just warn him that don't do this thing next time. But if you see that this medical student is doing the same thing again and again, then your next step will be just inform the supervisor of that medical student. We will not inform EFRA. This is not the mandatory reporting thing. So we will not inform the EFRA. Okay, doctors. Now let's move to the next question. A woman with 30-year history of schizophrenia. Okay, a woman with 30-year history of schizophrenia comes to GP for depot injection and lesion was found on her back to be melanoma. She was advised to have urgent biopsy. She became agitated and said, "Give me my report. What is the most appropriate next step?" A 10-minute interview, ask why she refused biopsy and refer her to psychiatrist. For these type of the question, for these type of the questions, doctors, please try to find the safe option. And second, try to find the option which is related to your safety, like which is related to your safety as well. In this question, the patient is already diagnosed with the schizophrenia and he is agitated at this moment. If you ask anything from her, maybe she will be more agitated and maybe she will harm you as well, or maybe she will do something to you as well, like maybe she put some like throw anything on your face, or anything can happen. So at this moment, because this biopsy, this is urgent, this is the urgent biopsy, but it is not like that you can do the biopsy now within within an hour or within 2 hours. No. So you just terminate the interview for now, and you will tomorrow maybe you will call her again, and you will, when she will okay, when she will not agitated, and when she will relax, then you will call with her, and then you will inform about the other things, and you will ask from her then why you are refusing the biopsy and why this biopsy is important for you and all these things. But at this moment, because she is agitated, terminate interview. Why I am terminating the interview? Because at this moment she is agitated. If I ask more questions from her, if I ask that why you are refusing the biopsy, maybe she will become more hyper, and maybe she throw anything on my face, or anything can happen. So it is good to terminate the interview at this moment. And I just call her on the next day. I called her and I asked from her that why you are refusing for the biopsy and all these things. This biopsy is important, and if still she said that no, I don't want to go for the biopsy, then yes, we will go according to her wish. So here, terminate interview. Handbook picture of lady with neck swelling. But next, aspiration cytology, CT scan, thyroid stimulating hormone, or ultrasound. Handbook picture of lady with neck swelling. We don't know that what is that picture, and we don't know that where this neck swelling is happening. Like it is on the midline. If it is on the midline of the neck, Maybe this is the, because the handbook question, there are the two or three questions related to the thyroid. In the handbook, one question is related to the thyroglossal cyst, and the swelling is on the midline. And the in the scenario, it is written that the swelling is moving with the protrusion of the tongue. So definitely, again, I'm saying that they will give you the like hint or the information, more clear information related to the question. So if it is the thyroglossal cyst, so they will give you the hint related to the cyst, that the swelling is moving with the protrusion of the tongue, or it is in the midline. So in that question, our answer will be ultrasound. But for this question, if I see that this question only, lady with neck swelling. For neck swelling, I don't know that this neck swelling is where, if the question comes only with the picture of the neck swelling, and I'm not sure that this neck swelling is on the midline or this neck swelling on the sides or anywhere. If the picture only, the question only comes with the neck picture, then my answer will be according to the RACGP guidelines. RACGP guidelines says that for any neck mass, your initial investigation will be CT scan to rule out the cancer first. This is according to the RACGP guidelines. We will not do the ultrasound. For any, it is clearly mentioned in RACGP, I will show you the explanation. It is clearly mentioned that for any neck mass, swelling, our initial investigation will be CT scan, not ultrasound, CT scan, to rule out cancer first. So therefore, I marked CT scan. I didn't mark ultrasound. Because first reason, the caller says neck swelling, and second reason, we don't know the picture. Maybe this question comes with only the picture. So if only the picture is there and you see that the swelling is on the neck, then mark CT scan. Mark your answer according to the RCGP guidelines. But yes, if the swelling is on the midline, and in the question they says that this swelling is moving with the protrusion of the tongue, then your diagnosis will be thyroglossal cyst. And we know that for thyroglossal cyst, we will do the ultrasound first. Then our answer will be ultrasound. So try to read the question very carefully, because I saw the doctors and they said that the RSGP says ultrasound, we will do the ultrasound in any case. No, not in any case. If it is the thyroglossal cyst, if it is the thyroid related disease, then no role of CT. Then we will do the ultrasound first. But yes, for any other swelling, for any neck mass swelling, maybe it is on the left side, right side, back, anywhere, your initial investigation will be CT. Okay, doctors. No, doctor, not for the any age. For the children, we will do the ultrasound. This is only for adults. So, first line investigation for all adults. This is only for adults. At risk of definitely more than 18 age. First line investigation for all adults at risk of malignancy consists of CT of the neck and contrast of fine needle aspiration. These two investigations provide complementary information of this. This is the adult with the neck mass. If the patient, if your exam question, if the patient is adult and the patient has the neck swelling, then your answer will be CT. But if the question is related to the thyroglossal cyst, if the swelling is on the midline, and in the scenario they say that the swelling is moving with the tongue protrusion, then your answer will be ultrasound. I am explaining you both things because in the handbook, the problem is that in the handbook, the question related to the thyroglossal cyst. In the recaller says that the handbook picture. So in the handbook, the neck swelling, the lady with the neck swelling, the question is related to the thyroglossal cyst. And in that question, the answer is ultrasound. But here the recaller says neck swelling. So we don't know that maybe this is the same picture of the handbook, or maybe this is something, maybe the recaller forgets. So therefore, I explain you both things. If this is the exact handbook question and the questions comes with the thyroglossal cyst, then your answer will be ultrasound. But if it is the other swelling, like not the exact handbook question, and maybe this is this other question, or maybe the swelling is somewhere else, like on the right or left side of the neck, then your answer will be CT. So this is all about, I think this is the last question. Okay, no, there's again, As is the same question. So, has always relieved by the drinking water. Patient noted to have history of mild eczema. So, what's the next investigation? Your trial of the PPI. So, let's just give me 1 minute. I will start the second file. Yes, doctor. So, what happened? No, doctor, nothing happened. Actually, I'm just saying that I will share the other file. That file for the day first was complete. So, therefore, I'm sharing the other file. Yes, doctor. So, yes, if there's the stent, yes, doctor, if there's the hydronephrosis, then it's stent. But if there is no hydronephrosis, then your answer will be according to the size of the stone. But yes, this is the distal, definitely in the distal, not in the, we can say the proximal, but if it's in the distal, your answer will be hydronephrosis. If there is the, sorry, your answer will be stent if there is the hydronephrosis, whether the size is less than 0.5 or equal to 0.5 or 0.5 or 0.7 or more than 0.7 in any size, if there is hydronephrosis, definitely if it is, definitely it is more than 0.7, therefore it is stuck in the distal and it causes hydronephrosis. So your answer will be stent. But if it is, if there is no hydronephrosis, then your answer will be according to the size of the stone. Yes, doctor.
Now, please, if you finish, you collect that.
Sorry, doctors, please mute. Okay. Next question is, there was a study of the lady who was diagnosed as mild dementia and advised to start on donizepam by specialist. Refuse any memory changes and cognitive decline. She lives alone. Her son and family also think she manages well. She does not want to take medicines. This question comes like I didn't see this question before July, but in July this question is very control question for so many doctors. And the doctor says that in this question is related to the dementia, and here the patient has a mild dementia, so we just follow the wish of the patient. I agree with this point. I agree with this point that for dementia patient, we always, like, if there's a mild dementia, if there's a mild dementia, we always follow the wish of the patient. If the patient don't want to take the medication, we will not give the medication. But here the problem is the patient is living alone. There was a this patient question for me, like when I saw the explanation in from RSCGP, I see that this question is not related to the dementia. This question is related to the elderly. If one elderly patient, if she is not living with her children and she's living alone, if she has not dementia, maybe she has anything else, like any other problem, okay, dementia or any other problem, if she's saying and she's okay, she's able to give the consent and she said, I don't want to go for the treatment, what you will do, you will not let her alone, like you will not let her without treatment, you will send someone to counsel her at her home. You will send someone, you will send the nurse or the council worker or anyone at her home. This is according to the RACGP. And this question is also related to the elderly. This question is not related to the dementia. There was a scenario of the lady who was diagnosed as mild dementia and advised to start on donizepam by specialist, refused any memory changes and cognitive decline. She lives alone. Her son and family also think she manages well. She does not want to take medications. The RACGP guideline says Understanding with elderly people stop taking medication. There are many reasons why older people may stop taking their medications, such as confusion about when and how it should be taken, feeling better and thinking they are no longer needed, or concern about becoming dependent. I am agree with this point as well, that this explanation is related to the taking medication, or we can say that the patient stopping medication. This explanation related to the stop taking their medication. In our question, the patient is not like she's refusing to take the treatment, but the hint in our question is she is living alone. We will not let her alone, like we will not let her without treatment. She needs treatment. So what we will do, we just send the nurse, or we just send the this social worker, or any like there's different people like the social worker or the nurses. We just send them to her home, and we will check that why she is refusing for the treatment. Maybe she has any problem at her home. Here this is the point. Their concern is that they about their concerns are about becoming dependent. They don't want to dependent on that because they are living alone. Please, doctors, try to get this point. Don't say that the patient has the dementia, mild dementia, so we will just follow the wish of the patient. I agree with your point that with the mild dementia, we always follow the wish of the patient if the patient is living with her family. Here the patient is not, so we must know the reason for the like why she is not taking the medication. We must know the reason behind this, and then we will follow the wish of the patient. So we send someone, we send the nurse or the social worker to her home to check that why she's not taking the medication. And then if everything is okay, if the nurse says that everything is everything good, then we will follow the wish of the patient. Because this patient has any problem, this patient is living alone, she is not living with her children. So here, ask her son to make sure she takes it also not, it's not the right answer, because we are not forcing someone to do this thing. Ask the community nurse to visit daily to administer the medicines. Administer the medicines is also like, we don't ask the community nurse to visit daily to administer the, but yes, we ask the community. Maybe this is the recaller made this mistake and for the administer the medicines thing, but this is the right option, that we ask the community nurse to visit her, because she is living alone. There is definitely, there will be some reason behind her problem, or behind her not taking the medications, because at this time, at this age, they think that maybe they will dependent on the treatment, therefore they don't take medications. So we just send the community nurse to her home, and that community nurse will counsel her, will tell her that this treatment is important for you, can take this treatment. So here the answer, ask the community nurse, is the more suitable answer. Tell her if she wants to live alone, she has to take the medication. Not, we don't force anyone. We don't force. We just send that community nurse. They will counsel the patient. They do the counseling things and everything, and then we will see that patient is taking the medication or not. But we will not forcing the patient to take the medication. Accept her decision of not taking medication is right answer, but not for this patient, because she's living alone. There must be some reason behind her not taking the medication. So first we will rule out that reason. Therefore, we will send community nurse to visit her, and then if everything is okay, and after the counseling and everything, she is still it's on that point that she don't wants to take medication, then we will accept her decision, because she has the mild dementia. So here, right answer, this is the right answer. Doctors, don't make yourself confused. This is the right answer, that asks the community nurse to visit daily to administer the medicines. Okay, doctors, let's move to the next question. Okay, doctor. So Which of the following, if normal, excludes malabsorption? So, serum iron, vitamin D, serum iron, vitamin D, and B12, and qualitative fecal fat test. So, this is the two tests I wrote over there. Initial test is hydrogen for the malabsorption. For the malabsorption, we always do the initial test, hydrogen blood test, and gold standard test is the fecal fat test. Because here it is, I will show, I think, what is the fecal fat test? A fecal fat test that measures the amount of the fat in your feces or stool. What is the purpose of this testing? Fecal fat test may be performed if your doctor suspect that your that your digestive system is not functioning correctly. In a normal person, the absorption of the fat is based on a variety of the factors. If any of these organs are not working properly, your body might not be able to absorb as much as fat as you need to remain healthy and nourished. Decreased absorption of fat can be a sign of many different illnesses, including these are the illness. So, yeah. So that's the question. These are the problems in which the malabsorption can happen, or we can say the the quantity of the absorption of the fat is decreased. So now let's see the other points. Other points are also important. Fetal fat test usually spend 24 hours, but can sometimes last for 72 hours. During the test period, you will need to collect each stool sample. Your local laboratory will provide you with the testing kit and these all these things. So I just want to shade one more line. Yeah, the concentration of fat in your stool can tell doctors how much fat your body absorbed during digestion. Changes in the stool consistency in order can indicate that your body is not absorbing as much as should. Okay. So here's I wrote that the initial test is the hydrogen blood test and the gold standard test is the fecal fat test. Here the thing is that from the other in the malabsorption the other nutrients also decrease, but they are saying that the which of the following if normal, like if for example if we take the serum iron level, if serum iron level comes normal, it doesn't mean that the patient has not malabsorption. Like serum iron level normal of the serum iron level will not exclude the malabsorption. Vitamin D, normal vitamin D level will also not exclude the malabsorption. These things, maybe these things will abnormal, or we can say the decrease in the malabsorption, but the normal, like if these nutrients comes in normal range, cannot exclude the malabsorption. But yes, fat absorption, fecal fat test, fat absorption, if this test comes normal, then it is says that maybe the patient has not malabsorption. Because as we see these conditions, here it is written that if any of these organs are not working properly, your body might not be able to absorb as much fat as you need to remain healthy and nourished. Decreased absorption of the fat can be a sign of many different illness, and these are the malabsorption: celiac disease, the digestive disorder, Crohn's disease, cystic fibrosis, and the pancreatitis. So, in these type of the diseases, our body cannot cannot absorb fat, and then malabsorption can occur. So, serum, if the patient has the normal serum iron level, I will not say that the patient has the malabsorption. Like the normal serum level cannot exclude the malabsorption. Normal vitamin D level, normal vitamin B12 level cannot exclude the malabsorption. But yes, if the fecal fat test comes normal, then yes, then our malabsorption will be excluded. And this is confirmed that initial test is hydrogen blood test and gold standard test for this diagnosis of the malabsorption is fecal fat test. Oh, sorry, I don't know why it happened again and again. Okay, so let's move to the next question. Okay, scenario for patient presenting with abdominal pain, few weeks duration, intermittently increased to sharping, radiating towards the back. Which test is the most? This is the question which I told you. I already explained you this question with the pseudocyst question. This is the pancreatitis, radiating towards the back, Study of the patient presenting with abdominal pain, few weeks duration, intermittently increased to sharp pain, radiating towards the back. Radiating towards the back is the more catching point for the pancreatitis. Now here they are asking most diagnostic test. What test is the most diagnostic? Serum lipase, abdominal CT scan, endoscopic pancreatography. So they are asking most diagnostic. I already explained you this question. I already show you the explanation from NSW guidelines. Then in that explanation, it is clearly mentioned that if serum lipase comes normal, then it doesn't mean that this patient has no pancreatitis. It means that serum lipase is not the diagnostic test, but the CT is the diagnostic test. It is clearly mentioned in the NSW guidelines. Then that if your clinical if you are clinical suspicious or if your biochemical test is not comes right, then your diagnostic test will be CT. So in last we will do the CT. So here they are asking most diagnostic test. They are not asking what is your initial. If they ask what is your initial test, then definitely your answer will be serum lipase. But here they are asked your most diagnostic, then most diagnostic is CT scan. So they here I have the same explanation. Oh my God, I don't know why this. And also the 7 steps, imaging, and all these things are there. So early ultrasound recommended and CT and all these things. So I already explained you these all slides. So I quickly move to the next question. Scenario of the patient presenting with abdominal pain, few weeks. Okay, same question. 48 years old. 48-year-old patient fall from a stair, sustained a Colles fracture. She is very concerned about her risk of developing further fracture. What to do next? So her age is 48-year-old patient and she fall from the stair and she sustained a Colles fracture. She is very concerned about her risk of developing future fracture. What to do next? Do nothing or bone density? Controllable risk factors. Controllable risk factors. Here our patient, here what are the risk factors? Like why we are doing the bone density and why we don't do anything. What are the risk factors? Uncontrollable risk factors are being over age 50. Like if the age of the patient is more than 50, then definitely we will do something for this patient. Why? Because age of the patient is more than 50. Being female. If the patient is female, again we will do something for the patient. Menopause. If the patient has the age of the menopause, we will do something for the patient. Family history of osteoporosis. Low body weight, being small and thin, broken bones or height loss. So these are the risk factors. In these patients, we will do something. We will not neglect the patient or we will not say that you don't need anything. No, we will do something for these patients. Being over 50 age, being female, menopause, family history of osteoporosis, low body weight, and broken bones or height. Here, the patient is only like she's 48 years, but she is female and being female and also 48 years. So near to, or we can say the menopause. So here she is at the risk factors. So we will do the bone density. So here the question is only the 2-line question. In the exam question, they will be more clear. Maybe there's the family history or maybe the other points give you. Therefore, I put this explanation over there. These are the risk factors. And for these risk factors, you must do something for this patient. Because we have only 2 options here. So we don't know that maybe what are the other 2 options. So for these patients, we will do something like we don't neglect the patient. Not getting enough calcium and vitamin D, not eating enough fruits and vegetables, getting too much protein, sodium, and caffeine, having an inactive lifestyle, smoking, drinking too much alcohol, losing weight. So these are also the risk factors. For these patients, also we do something. So just read and learn these points, and in your exam question, if there's any risk factor comes in your exam question, then mark bone density. Otherwise, if there is no risk factor in your question, then your answer will be do nothing. Okay, doctors, let's move to the next question. Scenario of a teenager started coughing 10 days ago, more common at night and with excursion, sometimes vomit and chokes of febrile treatment. Uh, One question asked, Doctor, what if the patient is not a schizophrenic patient and got agitated when asking for a biopsy from skin lesion? Are we still terminate the interview or can we proceed by asking the reason for refusing as that patient is not a psychiatric patient? No, doctor. In if the patient is if the patient is the if patient comes to you for any other reason and you we have one question and that question was related to the patient comes to you for any the female patient comes to you for any contraception and yes and you saw the acne on her face and you have some medications or you can prescribe pharmaceutical medications and so now what you will do like you will give the medications to her or you just give her the contraception thing so you just give the contraception thing so, because at that point the acne is not as such we can say the urgent thing so if she is concerned only with the contraceptive method then you can go with that thing and move forward it is not your responsibility to treat the other the non-urgent problems here the thing is that this is the urgent biopsy so she needs urgent biopsy and for agitated there must be the reason for the agitation it is not the normal thing that if it is like normal patient if comes to you for the contraception for anything and if you think that the patient has needs some biopsy on because of for the melanoma and you just tell her that you go for the biopsy if she is normal if she is not the psychiatric patient then definitely she will not be agitated but if she is agitated that there is some concern or there is she has some problem or the patient has some problems therefore she is agitated so just terminate the interview for that patient and then you can call her on the next side so they will give you in the exam question if they give the agitated word then they will give you the some psychiatric problem as well because normal person will not agitated with this thing and yes and if the normal person if the patient is normal and he is normal behaving with you and if you he's not agitated nothing and he comes for the for example if she comes for the contraception and you just saw the melanoma and you said that go for the biopsy of the this is urgent thing biopsy of the melanoma and if she said that no I don't want to go for this and then you can ask from her that why you don't want to go for the biopsy if she is not agitated if she is not agitated, then your answer will be ask the concern from her that why she don't want to go for the biopsy. Because it is not like because this is the urgent thing and this is the important thing. Melanoma is very like this is the cancer. So you can ask from her this is the very important or urgent biopsy. So if she is not agitated, if she is okay, if she is normal, and she comes to you for the contraception and you saw her the melanoma and you tell her that go for the biopsy this is urgent thing and if she said that no I don't want to go for that then your answer will be ask from the concern ask her concerns that why she don't want to go for that biopsy then your answer will be this but if she is agitated she is schizophrenic or any psychiatric problem and she is already agitated and she is shouting on you at that time you just terminate the interview you will not ask anything from her at that time maybe she will uh, put any harm to you okay so this will be our last question for today's session doctors so scenarios of the teenager started coughing yes doctor one doctor ask another question I think okay if it's in the proximal doctor if it is in the no I just saying that if it is in the distal if it is in the distal if it's in the distal ureter and the side then you will see that if there is the hydronephrosis then your answer will be stent but if it is not on the distal it is the proximal side then your answer will be according to the size of the stone And yes, if there is hydronephrosis, if the sorry doctors, if hydronephrosis word is there, that for hydronephrosis, try to find the answer stand, try to mark the answer, because this is the safe answer for the hydronephrosis. So mark stand, don't confuse yourself that no, we will not do the no, for the hydronephrosis we do the stent, and if there is no for the mild, still we will not do the stent. But if there is no hydronephrosis, then our answer will be according to the size of the stone. Yes, doctors. Okay, scenario for teenagers started coughing 10 days ago, more common at night and with excursion. Sometimes moment and shocks of febrile treatment. Febrile and treatment. So here the scenario of the teenager started coughing 10 days ago, more common at night and with excursion. Coughing, history coughing at night. For some time, I consider that maybe this patient has the problem of asthma. Maybe this patient has problem of asthma. But sometimes vomit and chokes. This vomiting give me the clue for the pertussis or whooping cough. Because as we know, for this whooping cough or this for this pertussis, we know that vomiting often follows a coughing spasm. Coughing is important for this, but vomiting is like followed by the coughing. In the AMC exam, they always use this line in the question, that vomiting followed by the coughing. So if there's only coughing overnight, so this is the nocturnal cough, so we can consider that this patient has the asthma. But if there is the vomiting followed by the coughing, that please try to consider pertussis, whooping cough. Then your diagnosis will be whooping cough, pertussis, not asthma. So here I made diagnosis pertussis caused by the caused by the bacteria, and then infants less than 6 months of age at risk of complications, all these things. Assessment diagnosis is largely clinical, and this is the history. Classic whooping cough, cough and cough for 1 week, followed by more pronounced cough in spells or proximal. So our patient has 10 days cough, history of the 10 days cough. Pertussis can also present a non-specific persistent cough. Infants may develop apnea or cyanosis with coughing spasm. Close contact with case of pertussis made as suspicious. Other family members frequently have a cough. More than 70% of the household contacts are also infected. Examination. Often there are no clinical signs. Children are usually well between coughing spasm. Observation of coughing spasm may be helpful. Fever is uncommon. Our patient is also febrile. Fever is uncommon. Laboratory confirmation is not necessary for diagnosis, but may be helpful for infection control. This is the thing, sometimes they ask the investigation as well. Laboratory confirmation is not necessary for diagnosis, but may be helpful for infection control. So therefore, if they ask what is an investigation, there is no need of laboratory test, but still sometimes AMC asks the investigation. Then your answer will be PCR. Nasopharyngeal aspirate or swab for PCR is the investigation of choice. For whooping cough pertussis, mostly laboratory confirmation is not necessary. But if in the AMC they ask what is the investigation for this pertussis or for whooping cough, then your answer will be PCR. Swab for PCR or nasopharyngeal aspirate. The test is usually negative after 21 days or 5 to 7 days. Now I have one other point related to the just 1 minute. Okay, management of the patient, antibiotics. But antibiotics we will give. Diagnosis in diagnosed and catarrh or early proximal phase may reduce severity. Cough for less than 14 days may reduce spread, reduce school exclusion period. Admit to hospital, complications. What are the antibiotic choice for the neonates? Azithromycin, children who cannot swallow tablets, azithromycin this dose, and children who can swallow tablets, azithromycin this dose. If macrolides are contraindicated, if it is the patient is contraindicated with the azithromycin or clithromycin, then your answer will be trimethoprim sulfamethoxazole. So just remember these points for the treatment of the whooping cough or pertussis. If the patient is neonate, this is the dose. If the patient is children, this is the dose. What is the antibiotics? Choice of antibiotics? Azithromycin or clithromycin. If the patient has allergy with macrolides, then your answer, contraindicated with macrolides or allergic, then your answer will be trimethoprim sulfamethoxazole. Now, school exclusion. Because In the AMC, they give their school exclusion question. Mostly they give their school exclusion questions as well. To exclude from the school and presence of other outside the home, you just exclude the patient from the school, or if the patient is neonate, if the patient is not a school going patient, then what you will do, you will do the other outside the home, especially infants or young children. For how many time? Like exclusion for how many days? Until received 5 days of therapy. Like you just start from, for example, if you start the antibiotic from Monday, that 5 days you must school exclusion will be finished at on Saturday, like after 5 days. So until received 5 days of therapy or coughing for more than 21 days. Maybe you remember I showed you one thing that after 21 days, here I showed something, I think. This one, patients are infectious just prior to or for 21 days after the onset of cough. When cough start, if the cough start on the day 2 or maybe if the cough start on day 3, for 21 days of cough, after 21 day of the cough, the patient will not be infectious. And then patient go to the school. The school exclusion is only for 21 days and your first day will be first day of the cough. Like 21 days of the cough. Or second, 5 days of the therapy. So these are the 2 points for the school exclusion. Until receive 5 days of the therapy, like because as we said that we start the treatment as early as possible. So if you start the treatment as early, not after the 21 days of the cough, you already start the treatment as before cough. So your answer will be 5 days. 5 days of therapy received, 5 days until receive 5 days of therapy. And if the question is related to the cough, that the cough for the more than 21 days, if the patient has cough more than 21 days, it means that now patient is not infectious. So now there is no need of exclusion or no need to of other family members outside of the home. So yes, doctor. So this is the vaccination and notification, because this is the notifiable disease. So we just notify the authority according for this patient or for this disease. So yes, doctor. So this is all about today's discussions. I hope you like the discussion. So in this way, we discuss the August recalls as well on the day 1, because as you see that I have only 2 or 3 hours, so I'll discuss the questions which I discussed on day 1. I will not discuss that questions on day 2 because I have no more time. I have only 2 hours. So, and I have more things like this is not only one recall, this is the whole topic. And I cover each and everything related to the topic. So therefore, I need some time to cover all questions. So therefore, I will not repeat the questions of day 1 on day 2. So if you have exam, this is my recommendation. Also up to you, doctors. If you have exam on the last day of the August, then it is good that you can book 5 days. In this way, you will receive all the 5 days recalls and all the 5 days recalls files. So you will receive the files and also the recordings as well. So these recordings are from August. These recordings will be for those who will join our course. And yes, only this recording, which this recording of this lecture, which I took today, this recording is only available in our WhatsApp group or in the MedExam Expert Telegram group, and in maybe I think they have the YouTube channel as well, and also the Facebook page. So you will find this video only, not the other videos, only this video. So thank you so much, doctors. I hope you like the session. Thank you.
Thanks, doctor.
Yes, bye.